Welcome back to our Pediatric Dentistry channel Tiny Teeth Talks. If you are new to this channel, subscribe the channel, and for details of this channel, visit the bio section, or you can also check out my previous videos. Today we will discuss child specific anxiety scales. So let's start. The Children's Fear Survey Schedule Dental Subscale CFSS-DS. The Children's Fear Survey Schedule Dental Subscale is one of the most widely validated tools for assessing dental fear in children aged 4 to 12 years. It is developed by the Cuthbert and Melamed in 1982 to assess dental specific fears in children, extensively validated across cultures, including Indian populations, used in both clinical and research settings to identify children needing behavioral management or anxiety interventions. CFSS-DS questionnaire items and scorings. So children rate each item based on how afraid they are of the situation or object. These are the items, which is basically 15 items, and the children have to score between 1 to 5. So the scoring will be 1 not afraid at all, 2 a little afraid, 3 somewhat afraid, 4 quite afraid, 5 very afraid. Total score range will be 15 to 75, and cutoff for high fear will be 38 or more than 38, which is depending on the population, but it has some limitations. So it is not diagnostic, so it screens for fear but does not diagnose anxiety disorders or phobias. Limited emotional depth focuses on the fear intensity but not coping strategies or emotional regulation. Cultural sensitivity. Some items like fear of blood or uniforms may vary in relevance across cultures. Parent child discrepancies. So children's self reports may differ from parental assessment, especially in younger age group. Static format doesn't capture changes over time unless repeated, lacks dynamic feedback. Less suitable for special needs, may require adaptation for children with the cognitive or communication challenges, and no physiological measures, doesn't include behavioral or physiological indicators of anxieties, for example heart rate or sweating. Then the modified child dental anxiety scale. The modified child dental anxiety scale is a validated child friendly tool used to assess dental anxiety in children aged 6 to 16 years. It consists of 8 items rated on 5-point scales with visual aids often used for the younger children. Developed by Wong et al. In 1998 as a modification of the original child dental anxiety scale, designed to be simple, age appropriate, and suitable for self-reporting by children, widely used in clinical research and school-based screening settings. These are the questionnaire items used in this scale. So these are the 8 dental situation you have to give to the child, and the child must score between 1 to 5. So 1 is not worried to 5 is very worried. Total score range will be 8 to 40, and high scores indicated greater anxiety. Cutoff scores vary by population. Some studies use 26 to 28 to indicate high anxiety. Advantages are simple language and visual support make it accessible. Quick to administer, under 5 minutes it's done. Validated in Indian, Asian and Western populations. Limitations. Not diagnostic. Screens for anxiety but doesn't assess coping or emotional regulation. Limited emotional depth compared to tools like STAIS. Less suitable for children with the developmental delays without adaptation. Then Frankel Behavior Rating Scale. The Frankel Behavior Rating Scale is a widely used observational tool in pediatric dentistry to assess child's behavior during dental visits. It categorized behavior into 4 levels, helping guide clinical decisions and behavior management strategies. It's developed by Sigmund Frankel in 1962. The Frankel Behavior Rating Scale is a non-verbal observational scale. It evaluates cooperation, anxiety, and emotional response during dental treatment, used extensively in clinical pediatric dentistry, especially during first visits and treatment planning and behavior guidance. Its category and description. First is definitely negative. If there is a definitely negative, and these are the symbol. Negative, this. Positive and definitely positive. Definitely negative, refusal of treatment, crying forcefully, fearfulness or extreme negativism. Negative, reluctance to accept treatment, uncooperative, some evidence of negative attitude but not pronounced. Positive, acceptance of treatment, cautious behavior, willingness to comply, good rapport with the dentist, interested in procedures, laughing and enjoying the situation. Scoring is categorical, not numerical. Used during or immediately after after treatment by the clinician or trained observer. Advantages are quick and easy to use in a clinical settings, non-invasive and requires no verbal input from the child, useful for the treatment planning, especially in behavior management and sedation decision, validated across cultures including Indian pediatric population. Limitations: subjective, depends on observer's interpretation, no psychometric scoring, cannot qualify anxiety or fear levels, not diagnostic, doesn't assess emotional or cognitive aspects of anxiety, limited depth, doesn't capture nuance like coping strategies or internal distress. And then Wenham Picture Scale, also known as the Wenham Picture Test, is a validated child-friendly tool used to assess situational dental anxiety in children as young as 3-year-old. It uses paired cartoon images to measure emotional states non-verbally. Developed by the Wenham and Gulin Kramer in 1979 as a projective self-report measure of anxiety designed for young children ages between 3 to 12 who may struggle with the verbal expression or abstract rating scale, used in pediatric dentistry to assess anxiety before or during dental visits. So this is the format. It consists of 8 pair of stylized cartoon figure, and each shows different categories, each showing one neutral or relaxed child and one anxious or distressed child. The first pair is calm and nervous, so he's calm and he's nervous. The second is happy or sad, he's happy, he's sad. And like this, there are 8 situations or 8 categories. Child have to choose between them. So the scoring: 0 is non-anxious figure selected, 1 is anxious figure selected. Total score 0 to 8. High scores indicated greater anxiety. Advantages: non-verbal and visual, accessible to children with the limited language and cognitive skills, quick to administer, take less than 5 minutes, validated, shows good internal consistency and test retest reliability, culturally adaptable, cartoon figures can be modified for local relevance. Limitations: binary scoring, doesn't capture intensity or nuance of anxiety, subjective interpretation, child's choice may reflect mood or misunderstanding, limited age range, less suitable for children over 10 or those with advanced verbal skills, no diagnostic depth, doesn't assess coping, emotional regulation, or physiological symptoms. The visual analog scale. It is a simple validated tool used to measure subjective dental anxiety or pain in both children and adults. In pediatric dentistry, it is often adapted with the faces or emojis to enhance comprehension. It is a psychometric response scale used to measure subjective experience like anxiety, fear, or pain. In dentistry, it is commonly used to assess dental anxiety, pain perception, treatment satisfaction. It consists of the horizontal line, usually 10 centimeter, anchored by two extremes, which is left 0, which is not anxious at all or no pain, and right and 10, extremely anxious or worst pain imaginable. And this is the response table. So 0 to 2, no or minimal anxiety, 3 to 4, mild anxiety, 5 to 6, moderate anxiety, 7 to 8, high anxiety, and 9 10, severe anxiety. Scoring measured in millimeters or centimeters from the left anchor. Cutoff score vary by study, often 5 or more than 5 indicates clinically relevant anxiety. Advantages: quick and easy to administer, non-verbal and intuitive, flexible, can measure anxiety, pain, or satisfaction, adaptable for children with the visual aids. Limitations: requires cognitive maturity. Children under 5 may struggle with the abstract scaling, subjective interpretation influenced by mood, environment, or comprehension. Single item, doesn't explore causes or coping mechanisms. Then the facial image scale is a quick child-friendly tool used in a pediatric dentistry to assess dental anxiety visually. It consists of 5 cartoon faces ranging from very happy to very unhappy, allowing children to express their emotional state non-verbally. Developed by the Buchanan and Niven in 2002 to measure situational anxiety in children aged 3 to 10 years. Designed for non-verbal or pre-literate children who may struggle with the abstract or text-based scales. Used in clinical pediatric dentistry to assess anxiety before, during, and after dental procedures. Children are shown a row of 5 cartoon faces, each expressing a different emotional state: very happy, happy, neutral, unhappy, very unhappy. The child is asked, which face do you feel like right now? Scoring: the selected faces score 1 to 5 reflects the child anxiety level: 1 to 2 low anxiety, 3 moderate anxiety, 4 to 5 high anxiety. Advantages: non-verbal and visual, ideal for young or non-verbal children, children. Quick and intuitive, takes less than 1 minute to administer. Validated, show good reliability and correlation with other anxiety scale. Culturally adaptable, faces can be modified for local relevance. Limitation, single item scales doesn't capture intensity or cause of anxiety. Subjective interpretation, child's choice may reflect mood or misunderstanding. Limited age range, less suitable for children over 10 or those with the advanced verbal skill. No diagnostic depth, doesn't access coping, emotional regulation, physiological symptoms. And then the Smiley Faces program, it is a visual child friendly tool used in pediatric dentistry to assess dental anxiety and emotional responses. It uses a series of expressive cartoon faces to help children non-verbally communicate their feeling before or during dental treatment. The Smiley Faces program is a projective non-verbal scale designed for young children, especially 3 to 8 years. It is used to assess situational dental anxiety, emotional state, or treatment satisfaction. The tool is based on the principle that children can more easily identify with the facial expression than abstract verbal scales. So these are the formats. So the children are shown a series of cartoon faces, usually 5 or 6, and each depicting a different emotional state. So these are the faces expression and these are the score. So child is asked which face shows how you feel right now, and same as lower scores indicating positive emotions or low anxiety, while higher reflect negative emotion or high anxiety. Advantages: non-verbal and intuitive, accessible to children with the limited language or cognitive skills, quick to administer, take less than 2 minutes, culturally adaptable, faces can be modified or local relevance, correlates well with other pediatric anxiety scales like FIS and VPS. Limitations: single item scales, doesn't explore causes or intensity of anxiety. Subjective interpretation, child's choice may reflect mood or misunderstandings. Limited age range, less suitable for children over 10 or those with the advanced verbal skill. No diagnostic depth, doesn't access coping, emotional regulation, or physiological symptoms. Then the anxiety thermometer. The anxiety thermometer is a simple visual analog tool used in a pediatric dentistry to assess a child's current level of dental anxiety. It resembles a temperature scale and allows children to self-rate their anxiety from calm to extremely anxious. The anxiety thermometer is a single item self-reported scale modeled after a vertical thermometer. Children are asked to mark on a point on the scale that best represent how anxious they feel at that moment. It is used in the pediatric dentistry especially for pre-treatment screening, behavioral planning, and monitoring anxiety over time. So the thermometer level: bottom cool, which is very calm, not anxious, score 0. Midpoint mild to moderate anxiety, which is 5, and the top hot, extremely anxious, panicked, 10. Scoring 0 to 10, interpretation 0 to 3 low anxiety, 4 to 6 moderate anxiety, 7 to 10 high anxiety. Advantages: quick and intuitive, takes less than 1 minute to administer, visual and non-verbal, ideal for children with the limited verbal skills, flexible, can be adapted with the emojis, colors, or cartoon figures, correlate with the other scales. Limitations: single item scale, doesn't explore causes or coping mechanisms. Subjective interpretation may be influenced by mood or misunderstanding. No diagnostic depth, doesn't assess emotional regulations or physiological symptoms. Then the Morin's AFDTCI assessment form of dental trait and clinical impact. So it is a structured tool designed to evaluate both trait, dental anxiety, and clinical consequences in children. It combines psychometric rigor with clinical relevance, making it in a unique contribution to pediatric dental anxiety assessment, which is developed by Morin et al. So to assess the trait, dental anxiety, and the clinical impact. It is used in the pediatric dentistry to guide behavioral management, treatment planning, and referral decisions. So the structure will be trait: dental anxiety, same assess general fear of dental procedure, instrument, and settings. Item typically rated on Likert scale. Clinical impact subscales are the evaluates how anxiety manifests during treatment, like refusal, crying, avoidance. So simple. If the my child is afraid of dental drills, which is the trait anxiety, which is the anxiety due to the instruments, and my child avoid dental appointments with the clinical impact. So they show the clinical impact. My child cries during dental visit. It also shows the clinical impact. But my child worries about dental pain, so it is a trait anxiety created by situation. Total score interpretation, high scores is equal to greater anxiety and clinical interference. Cutoff scores vary by population and study. Advantages, dual domain structure captures both emotional and behavioral dimensions. Clinically actionable, links anxiety to treatment outcome. Flexible administration, can be adapted for self-report, parent report or clinical observation. Limitations, limited global validations, primarily studied in French-speaking population. Required training, clinicians need familiarity with scoring and interpretation. Not widely available, may require permission or translation for use outside original context. Coming to the recent advances, so DVCPDAQ, Deepak Vishwanath's Child's Perception Dental Anxiety Questionnaire. It is a child-centered, culturally adapted scale designed to assess dental anxiety in Indian pediatric population. It uses cartoon-based visuals and simplified languages to capture children's emotional responses to dental situations. It is developed by the Deepak Viswanath, is visual and verbal scale tailored for Indian children aged 5 to 12 years. It emphasizes child perception, combining cartoon illustrations, simple questions, and emotive cues, designed to overcome limitations of Western scales like CFSS, DS, and MCDS in Indian settings. So these are the questionnaire format, include 10 questions, and the responsive format are 1 to 5. Scoring 1 very happy and not anxious, to 5 very scared and highly anxious. Total 10 to 15. Interpretation, if 20 and lower than 20 then low anxiety, 21 to 35 moderate anxiety, and 36 and more than 36 high anxiety. Advantages are culturally relevant, developed for Indian children with the familiar visuals and language. Child centered, focuses on child's own perception, not parental or clinical rating. Visual and engaging cartoon based format improves the comprehension and participation. Validated, shows strong internal consistency and correlation with the CFSSDS and MCDAS. Limitation, limited global validations, primarily tested in Indian population only. Requires visual materials, not suitable for text only administration. Single domain focus, doesn't assess coping strategies or emotional regulation. And the second is digital or app based scale adaptations. Recent digital innovation include tablet based variation of the facial image scales and the visual analog scales with the animated faces or sliders. Real time data capture and biofeedback integration, like heart rate monitoring to correlate physiological and emotional responses also. And enhance child engagement and reduce observers bias. So these are the references of all part 1, 2 and 3. If you want this as a PDF or any other PDF, just like, subscribe and comment your mail ID with the topic, and I'll share you the PDF new videos on Sunday. We also put lots of MCQ related to pediatric dentistry with topics revisions on our shorts. So press the bell icon for every update. Like, share and subscribe. Thank you.